Good afternoon, everybody. I am Sarah Dash, President and CEO of the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Since March, the Alliance has hosted dozens of programs to provide insight into the COVID-19 response. You can find additional resources and recordings of those webinars on our website, allhealthpolicy.org. The Alliance for Health Policy gratefully acknowledges Arnold Ventures for supporting today's webinar. You can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We truly want you all to be active participants, so please get your questions ready, and here's how you do it. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. Use that icon to submit questions that you have for the panelists at any time. We will collect them and address as many as we can during the broadcast. And you can use that icon in case you're having any technical issues. Check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available there soon. Today, our panelists will discuss options to mitigate the financial impact of COVID-19 on healthcare providers. Hospitals and outpatient care entities are facing prolonged financial pressure as COVID-19 continues to spread across the U.S. Many have incurred increased costs to safely care for patients with COVID-19, and at the same time, utilization of non-COVID related healthcare services is falling, which has had devastating impacts on provider revenues. Congress and the administration have taken several actions to deliver aid to hospitals, health systems, and outpatient healthcare practices, but some providers most in need have faced barriers to these funds, and many continue to grapple with immense financial losses. Today, I'm delighted to be joined by a group of all-star panelists to discuss these issues and raise considerations for policymakers as they weigh additional options to support providers. First, I am pleased to introduce Billy Wynn, Chairman of the Wynn Health Group, a national public interest health policy consulting firm providing strategic counsel and advocacy services to elite healthcare organizations. Billy previously served as health policy counsel to the Senate Finance Committee. Next, we will hear from Karen Schwartz, who is a senior fellow at the Kaiser Family Foundation. Karen previously worked as a vice president for pharma and served in the office of the Assistant Secretary for Planning and Evaluation at Health and Human Services. Next, we're pleased to be joined by Ken Kaufman, who is the chair and founder of Kaufman Hall, where he helps hospitals and other healthcare organizations with critical strategic challenges. Next, we'll hear from Susie Desai, who is a senior director and sector leader for the not-for-profit healthcare group at S&P Global. Susie is responsible for all aspects of the healthcare practice, including criteria development and analytical thought leadership. Finally, I'm pleased to be joined by Mark Miller. Mark is executive vice president of healthcare at Arnold Ventures, and prior to joining Arnold, Mark was the executive director of the Medicare Payment Advisory Commission. Our panelists are going to open with a few minutes of remarks, and then we will open it up to questions from the audience. So again, as a reminder, feel free to get those questions rolling, and we'll take as many of them as we can. With that, I'm going to turn it over to Billy Wynn. Billy?
Thank you so much, Sarah. Thanks to you and others at the Alliance for Health Policy for having this event and inviting me to participate. My goal here is to briefly provide some broader context for the funding streams flowing to providers to help them respond to the COVID pandemic, and talk a little bit about where I see things going from here with regard to congressional allocations and so forth. And I know that others are going to go into more detail on how the funding's been allocated and some of the issues relating to that. So first of all, as Sarah alluded to, Congress and HHS have taken several steps to support providers in addressing the pandemic that we're currently experiencing. In the CARES Act, the so-called Phase 3 COVID response bill, Congress appropriated $100 billion to the Provider Relief Fund. In the 3.5 bill that included an extension of the Paycheck Protection Program and other items, they appropriated another $75 billion. So today we have $175 billion in the Provider Relief Fund. I do want to quickly distinguish the, I'm going to call it the PRF, from other funding streams that are that providers are eligible for, including, for example, the Medicare Accelerated Payments Program, where providers can receive up to 3 to 6 months of anticipated Medicare payments in advance. Unlike the Provider Relief Fund, currently those payments are required to be paid back. They are loans, although there are some advocating for forgiveness, at least partial forgiveness of those loans, and we'll see kind of where that leads. CMS has also taken some steps under the public emergency declaration to expand access to things like telehealth, to create add-on payments for COVID-related inpatient admissions, et cetera. That public health emergency, by the way, I'm sure many of you saw, was recently extended into late October. So those programs can continue at least that long. Here too, some have called for extending those programs. In particular, I'd note the expansion of access to telehealth services even after the COVID pandemic subsides. Lastly, I just want to quickly note the Paycheck Protection Program, the PPP. Several healthcare providers have received those dollars, in particular, especially in the smaller $150,000 and below allocations. A lot of physician and dentist offices, childcare services, and others have received some of that money. So we've got lots of different streams flowing to providers. I just wanted to quickly flag some of those other items, just in part to make sure we don't have confusion about which is which. I would just say at a broad level, so far there have been some criticisms. I guess is inevitable of a program of this size and speed of the PRF. CMS has, as I think Karen and others will get into, there's still about I think $60 billion or so of the $175 billion that has not been dispersed. There has been some criticism of that. There's of course been criticism in the various ways and methodologies in which HHS has chosen to release the funds. It's had pretty broad latitude to make those determinations. HHS's response is that because of the uncertainty of additional congressional funding, they've wanted to take it a bit slower in terms of allocating the funding that they have. If Congress does allocate new funding, I think you would see some of those pre-existing dollars get out of the door much more quickly. But that's kind of the high-level debate going on in that regard. In terms of what is next, just briefly want to comment that I'm sure everybody is watching closely the negotiations around the 4.0 COVID relief measure. The House has a bill, of course, Democrat-led House, that would provide a total of about $3.4 trillion in total COVID relief, including $100 billion of new funding for the Provider Relief Fund. The Republican-led Senate has put out a proposal that has $1 trillion of total COVID relief and $25 billion allocated to the Provider Relief Fund. So clearly a large gap. I think that generally the commentary coming out of yesterday's negotiations did not give us a lot of optimism that we'll see a swift resolution of those differences. But as we move into campaign season, I think both parties are under a lot of pressure to deliver something in terms of future COVID-related relief. So there are some other items under consideration in that package, and with this I'll stop and pass the baton. But for example, the Democrat bill includes an increase in the FMAP funding, Medicaid-related funding to states, a separate bucket of state and local aid funding. The Republican Senate bill has liability protections for providers on the other hand. And then both parties are also appear to be intent on continuing unemployment benefits, though they're far apart in terms of the size and the details with which that funding would be distributed. So hopefully that's a helpful overview. Thanks again, Sarah, for having me, and I'll look forward to the questions of the participants.
Great. Thank you so much, Billy. And now I'm pleased to turn it over to Karen Schwartz, who has some slides to show us as well.
Great. Thanks so much, Sarah. So we can move ahead to the first slide, and I'm going to be walking you all through the $175 billion in provider relief grants in a little bit more detail. You know, as Billy mentioned, Congress gave HHS very little guidance on how this $175 billion in grants should be distributed. They essentially just said the money should go to healthcare entities and could be used either for expenses related to COVID-19 or for lost revenue due to the pandemic. What HHS has chosen to do so far is allocate these grants in 2 larger buckets and then smaller chunks within each of those buckets. So first, HHS made what they call general allocations, first to Medicare providers, and then later they opened this up to Medicaid providers and dentists. And each of these allowed providers to receive grants that amounted to 2% of their net patient revenue. And as I'll discuss later, there's winners and losers with this formula. HHS has also made targeted distributions to specific types of providers that may have needed more assistance, namely hospitals that treated a lot of COVID-19 patients, safety net hospitals, rural providers, and others. We can move to the next slide. All right, there's a lot of numbers on this pie chart. I apologize, but I do want to draw your attention to a couple things on this pie chart, which shows how the money has been distributed so far. So in total, a little less than $15 billion is going to Medicaid providers, and then another $12.8 billion is going to safety net hospitals. So this means in total, less than $30 billion is targeted directly towards the safety net. And these safety net providers are operating often on the thinnest margins and maybe those most in need of help right now. And additionally, when these providers provide free care to the uninsured, that care is not factored into that 2% of net patient revenue formula, since, as we all know, 2% of zero is still zero. So no general provider relief grants were given out that accounted for charity care for the uninsured. You know, as Billy noted, another thing that's interesting in this pie chart that you'll see is there's almost $60 billion that's still left to be distributed. Some of that money is being used to reimburse providers for treating uninsured patients, but considering that the CARES Act was signed into law in late March, that's a lot of money left to be distributed. Providers who accept this money do not have to meet or do have to meet certain terms and conditions. Notably, they're not supposed to balance bill out-of-network patients with COVID-19, but it's not clear how many patients are aware of this protection and how well it's being enforced. Could move to the next slide. Thanks. So we did some analysis of the Medicare general distribution, and what we found should really not be surprising. Allocating grants based on a provider's general revenue tends to favor the providers who get paid more. So a lot of this is driven by how much revenue a provider gets from private insurance, which tends to reimburse at higher rates, typically twice as high as Medicare rates, and sometimes much more than that. So in looking at hospitals with the highest share of revenue from private insurance, they got more than twice as much money per hospital bed than the hospitals with the smallest share of private insurance revenue. The hospitals that fared the best were more likely to be for-profit, had higher margins, and provided less uncompensated care. And while we just looked at hospitals, the same patterns would hold for other providers. And I want to take a moment just to talk specifically about Medicaid providers. These are providers that either primarily or exclusively serve Medicaid patients, and they provide crucial services such as behavioral health and long-term care. HHS waited several months before announcing the start of the application process for provider relief grants for Medicaid providers, and they just extended the deadline for those providers. Medicaid providers are often operating on very slim margins, and any decrease in revenue or increase in costs due to COVID-19 would likely be particularly challenging for them to absorb. Also, Medicaid providers could end up facing cuts in reimbursement rates. States often cut Medicaid reimbursement during economic downturns as a way of saving money. To help states manage the cost of Medicaid, one of the earlier coronavirus packages that was signed into law included a 6.2 percentage point increase in the federal share of Medicaid spending, or the FMAP. However, that increase in federal contribution is tied to the public health emergency declaration, so it's unclear exactly how long it will continue. And additionally, this increase in the federal share of Medicaid is unlikely to fully offset state revenue declines at a time when we expect Medicaid enrollment to be increasing, further straining state budgets. As Billy mentioned, the House would increase this FMAP aid. So that's all I have for now. On the last slide, you can see a list of KFF resources related to this topic.
Great. Thank you so much, Karen. And just kind of a definitional follow-up, if you don't mind. What you did a great job outlining the differences between Medicare and Medicaid and safety net providers, but just, maybe for those who haven't gotten as much into the weeds. I mean, what can you say a little more about the difference between Medicaid providers and safety net hospitals? Like, where's the overlap and what are the differences?
Sure. So the safety net, HHS did provide extra money to safety net hospitals using an eligibility formula that they created to essentially try and ensure that its hospitals that have lower margins are treating a higher share of Medicaid patients and providing more uncompensated care. Some of the specific Medicaid providers we're thinking of aren't necessarily hospitals. It's providers that provide a lot of long-term care services, behavioral health services, some of the community health centers, so non-hospital providers that are really focused on Medicaid populations.
Great. Thank you so much for that clarification. So now I'm pleased to turn the conversation over to Ken Kaufman of Kaufman Hall. Ken, go ahead.
Thank you so much, and thank you for inviting me this afternoon. So I'm going to talk about the evaluation of the actual financial damage done to the provider hospital community and sort of look at where we stand at the moment. So we did a recent report for the American Hospital Association looking at what had happened over the April, May, June time period. And we focused on one metric in order to keep things simple, the operating margin. And the operating margin, of course, is the amount of money or loss that hospitals are incurring in the difference between operating revenue and operating expenses. So in the past, the typical median for the operating margin for hospitals across the United States is about 3.5%. So generally, hospitals run on pretty thin margins compared to organizations that operate in different industries. In the first quarter of 2020, which included sort of 2 to 3 weeks of COVID cases, the median margin fell to less than a -2%. So in other words, we started at about 3.5%, and then the median went down to less than 2% in the first quarter. In the second quarter, when we saw COVID cases throughout the quarter, the median margin fell to less than 3%. Now, we should probably talk about what happened in the second quarter because it's pretty important. So the COVID cases hit across the country, although they were concentrated in just particular areas at that time. But all hospitals across the United States had to prepare for the COVID cases, so they took the responsibility for additional expenses in order to get ready to take care of the COVID cases, or in fact, in some areas, actually take care of those cases. But what happened next was the real financial damage, and that was many hospitals decided that because of the COVID situation, they had to stop elective surgeries and elective outpatient services from coming to the hospital. So they shut that all off. In other cases, it wasn't the hospital's decision. It was a regulatory decision where many mayors or governors across the United States instructed hospitals to stop serving elective surgeries. This went on for roughly about 2 months. And hospital revenues across the country generally wound up being about half of budget. So take it that a hospital expected to have revenues in the month of April of $100 million. Many of those hospitals in many parts of the United States wound up with only $50 million. The losses were really dramatic in every size and type of hospital in the United States. That's when the CARE funding kicked in. And without the CARES Act funding, the Q2 margin would have been negative 15%. So that gives you all an idea out there of how important the CARES funding was. I talk to hospital CEOs all the time as just part of what I do. And a number of them have reported to me that without the CARES funding in that critical April, May, June period, there would be a good chance that they would not have made it through that period, that they would have not been able to make payroll. So then what is essentially the slope of the recovery curve, the slope of the revenue curve? So if you'll just recollect that that some hospitals were at 50% of expected revenue in April and May, how soon will that revenue come back, and to what level will it come back? Will it come back to 100% or 95% or 90%? And so we're watching that very carefully. That has been complicated by the fact that we're having another surge now. We're having that surge generally in other places where we didn't have the surge before. But this has really become a whack-a-mole thing with hospitals just trying desperately to stay ahead of what they either expected or didn't expect to happen, and nobody really is able to follow it very well at this point. So our projection is that without further government funding, the median margin will fall perhaps as low as negative 7% in the second half of the year. But depending on the path of COVID, which, as I just indicated, none of us can really figure out at this point. Are we going to have a surge back in the Midwest? Are we going to have a surge back in the Northeast? I know that cases were jumping back up in Wisconsin, jumping back up in Missouri. And I know the governor of Illinois is very concerned about Southern Illinois. So our projection was that the median margin would be any range from 1% to negative 11% by year's end, depending on what demand developments occur because of the path of the disease. And then very importantly, the impact will not be equal for all hospitals, and we're already seeing that. So we think half of America's hospitals could have negative margins between now and the end of the year, but it's extremely hard to predict which of those hospitals will have negative margins and which of those hospitals will begin to recover. We are beginning to see that some of, at least on a very unscientific basis, it appears that some of the academic medical centers are coming back very quickly, and perhaps community hospitals coming back less so. And so what does this mean in terms of hospitals and their communities? Well, hospitals with weaker financial health are going to be forced to contend with the immediate pressures on their ability to perhaps survive or thrive. Many hospitals are already understanding that they're going to need to make major changes in their cost structure in order to adjust to a loss of revenue whose exact level still remains unknown. Capital projects and capital budgets all over the hospital business across the United States have been either paused or stopped entirely. And then you all know that workforces have been impacted in a significant way. We've had furloughs and then we've had actual layoffs. But I would say up till this point, the furloughs and layoffs actually haven't wound up being as severe as you would have expected, given the numbers that I just reviewed. I think many hospitals have tried very hard not to permanently impact their workforce as they try to figure out exactly where they're going to wind up from a COVID perspective and exactly where they're going to wind up from a financial perspective as this thing continues to move forward. So I will stop there, and I will look forward to answering any questions anybody may have. Thank you very much.
Great. Thank you so much, Ken. A lot of great questions, and we're getting some really great questions already kind of coming in from the audience. So we're going to get to those. So please go ahead and fill them in. Ken, let me ask one that's kind of related to an audience question, which is kind of around telehealth. And have you seen any impact, of improved revenue from hospitals or health systems that are using telehealth, or is it too early to tell what the impact is?
Well, I mean, telehealth was a savior. I mean, there's absolutely no doubt about it. The history of telehealth in provider healthcare is rather remarkable in how slowly it developed compared to the use of telecommunication and other industries. But once the COVID hit, patients had to use it, and doctors had to help out. And that resulted in amazingly significant changes. We had hospitals report to us that they were doing 500 telehealth visits a day before COVID, and then after COVID they were doing 5,000 a day. I mean, they were just all that kind of thing. And a number of the payers and of course Medicare pitched in and agreed to pay much better dollars for the telehealth visits. But I don't think we've seen any analysis that we can count on as to how much it helped. It certainly helped in that it gave doctors and hospitals the incentive to really jump in and do everything they could from a telehealth perspective and protect their patients from that point of view. But I don't think we don't have an analytic yet that tells us how that turned out financially.
Great, thanks. Let me just follow up with one other one, since it is pertinent to what you had mentioned around how not all hospitals are kind of being affected the same. Somebody in our audience asked what explains why academic health centers appear to be rebounding more quickly than community hospitals. Do you have any insights that you can offer there?
Yeah, I do have an insight. And basically, over the last 20 years, academic medical centers have worked incredibly hard to differentiate themselves by accumulating very capable doctors and being able to do on a consistent basis very high-end tertiary and quaternary care. I think we can all speculate that as those are individuals who really needed to get back to their care, they paused it while the COVID virus was in full rage, and many of the academic medical centers were not accepting any kind of elective care during that part of the pandemic. But once they had a sense and that the hospitals provided safety measures, those people who didn't just want, they needed to get back as quickly as possible. And I think that's a differentiator between the academics and the community providers.
Great, thank you so much. That's helpful. So Ken, thank you. And I will now turn it over to Susie Desai from S&P. Thanks for taking a break from earnings season to join us.
Thanks, Sarah, and thanks for having us, and I hope everyone is staying well and healthy out there. And I'm going to talk a little bit about the non-for-profit hospitals and COVID from a credit rating standpoint. And I think a lot of the comments actually resonate with what Ken just talked about, as well as Karen and some of the folks earlier. But before I do that, I just want to level set a little bit so we can go to the first slide, just what we do and who we are. So one more slide, please. So we provide credit ratings, which is the likelihood and willingness of issuers to pay their bonds back. And bonds are generally issued, as you know, for strategic initiatives like capital and technology and all of that good stuff. And as you know, hospitals are a very capital intensive sector. So in order to determine that, we have specific criteria we use for acute care hospitals. And that criteria incorporates a model, but also a lot of analytical judgment and understanding of the sector and discussions with management teams about what's going on for that particular credit. Our ratings are reviewed annually, and we update that with data as well as discussions with management teams. We rate about 420 hospitals and healthcare systems across the country, and if you include all the health hospitals that are under all those bigger health systems, it's quite a big, it's a good representation of what's going on in the sector. And the hospitals we do rate vary from small critical access hospitals to community hospitals, academic medical centers, regional health systems, and multi-state systems. So if you go to the next page, and not to get into the weeds on our criteria, but just to give a snapshot of what we look at, because this is going to impact how we're thinking about the sector right now. We obviously look at a lot of the financials for the non-for-profit hospitals, including their performance and their balance sheets and the debt that they have and the liabilities. But really what's informing that is what we look at as the enterprise profile. So that's who that credit is, where are they located, what kind of service area are they in, what type of services do they provide. Ken talked about the academic medical centers, which are a different breed than the children's hospitals. We look at the medical staff, how integrated they are, what their strategy is. So it's a lot, and a big piece, which I know we'll talk a little bit more about, is the payer mix of that hospital and what that's made up of. So is it Medicare, Medicaid, commercial? Do you have multiple Medicaid if you're sitting on a cross-state type of system? And then we look really at management teams and the governance to really understand what the strategies are. And that really informs our view of a credit and the strength and the stability of that credit and the risks that are there. So if we go to the next slide. So entering into 2020, so this is a slide actually from our stable outlook that we had back in January. And you can see there were a lot of pressures actually just coming into the sector before COVID even hit. But obviously once COVID hit, we did revise our outlook to negative on the sector, which doesn't mean that all of our credit ratings went to negative in terms of our outlooks. But what it meant was that we just thought that there was more likelihood of credit changes to the negative side, be it outlooks or be it rating downgrades. There were a few items here, though, that I just want to highlight with the management strength, financial flexibility, and business profiles that we'll talk a little bit more about, but have really helped some of the credits that we rate maintain stability during this very challenging time. So if we go to the next slide. Just a quick snapshot of our rating distributions. As you can see, we rate from AA+ down to speculative grade. So it does vary, but you can see the non-for-profit acute care hospitals generally are in the investment grade, which is everything above BBB- and above category. But you can see that standalones are a little bit more riskier. They skew to the right there a bit towards the low A category, BBB, and then the systems are at the higher end. What's I think interesting here is looking at our outlook. So we do tend to look at things from a standalone versus system standpoint. Systems are generally those hospitals that have more than 3 hospitals under their system, but generally have even much more than that. But you can see here the outlooks. When we were at the end of last year, we were you can see where the percentages were and how those kind of ballooned kind of as of June 30th, and we went from 14% negative outlooks to 26% on the standalone. And even the systems, which are generally more stable, they went to 17% on the negative outlook. So during this time, though, I will say we've tried to take a measured approach to our credit ratings. And really what you'll see for the outlooks that have been changing are those that have weak liquidity, weak business positions, generally in the speculative grade or lower rating categories. Or those credits that have had challenges just coming into the pandemic. So even before the pandemic hit, they were already going through some operating challenges or balance sheet stress. So that's where you see more of the outlook changes. And if you go to the next slide, you can see that we still have a fair amount. These are all the credit ratings that we have reviewed through June 30th. And we've had a fair number that have maintained their current rating. And that's where I say we've taken a measured approach, and some of these credits are holding steady for now, but you do see a significant number that have had unfavorable outlook revisions, meaning they're probably going to a negative outlook, and some downgrades as well. We're a little bit ahead of where we were last year on downgrades, and then very few sort of positive indicators there. So that's kind of how our ratings have performed. And if we go to the next slide, this kind of gives a little bit of the story then of where are we today. So we're here in August, and I think Ken and highlighted some of the challenges that all the credits went through in March and April. Again, it wasn't even for every credit, but certainly all the credits experienced some level of stress. As we sit here in August, we have seen we've seen good volume recovery in May and June and July, starting maybe at the end of May, June, July, August. Like Ken mentioned, that's getting a little muddied by some of the surges that we're seeing across the country in different markets. But generally, and I think similar things that we've seen, that some of the academic medical centers, those places that are serving tertiary quaternary kinds of services, those are coming back. But we're also looking that is this pent up demand because no one's gone to the hospital for a couple of months, and how is that flowing through, and is that going to hold up, especially as patient behavior may change, just given the social distancing and some of the concerns around health and safety. So really watching that. So we do think it's going to be an uneven volume recovery as we see these ebbs and flows over the next several months to going into early next year. We don't think that we're going to see that full shutdown. Again, we've seen even in these surge markets that they're continuing to provide some of that elective and non-emergent care. But it really is it complicates things for hospitals as they have to deal with these mini surges and how to manage their COVID and non-COVID cases. The other big thing, and I'm sure we'll talk more about this, is the recessionary environment. Obviously, shifts in Medicaid. We're keeping a close contact with our state rating analysts as states are under a lot of pressure, those cuts. And then also looking at the underinsured and uninsured, perhaps also causing some challenges there, challenges being weaker reimbursement and potentially lower volumes as people delay getting care if they have to do more out of pocket. So these things are all going to lend to margin pressures over the next rest of this year, probably going into next year. Won't be the extreme that we saw in April and March and April, but we do think that that's going to be a negative headwind there. And we are seeing the staffing costs increase, supplies are increasing. And so those are things that we're watching, and how that moves through the system, and how the volumes continue to be affected. And of course, the federal stimulus grants have helped, and have certainly blunted the margin pressures that we saw in the second quarter. But we're, as those MAP funds are having to be repaid, a big question is going to be cash flow, and will they be able to be paid off without impacting the balance sheets? And also, the lines of credits and other things that hospitals have used, will those be able to be paid off, or will they need to keep those on there? And what does that do going forward for these hospitals? So where we stand, credit fundamentals matter. We still think our stronger credits, those that are, should be able to better withstand the pressures from the COVID, but prolonged stress could really, could cause some challenges there. Management teams are working on expense cuts. I think, again, Ken mentioned that. And I think being that we haven't seen what that new normal is, it's hard to make the big strategic cuts that might be necessary, but they're certainly looking at those and thinking about those going forward. We think the credit quality gap is going to widen, so the stronger credits are going to continue to probably stay strong, and the weaker ones are going to have a hard time being able to kind of stay stable, but also then reinvest, because that's going to be very important going forward, to continue to reinvest with technology, with the capital needed going forward. So, and I know we'll talk about many of these things here, but a lot of these other things like health policy decisions, the election, how those all affect healthcare going forward, is certainly a question mark. And, the government's going to be under a lot of pressure from having done all this support. So Medicare is going to continue to be a focus, and cost cuts there. So I'll pause there, but I'm sure we're going to get into more of these as we continue the discussion, but happy to take any questions.
Great. Thank you so much, Susie. This is really great, and you covered a lot of ground here. I want to ask you kind of a little bit of an operational question. When you talk about these like unfavorable outlook revisions, and then just the very few sort of favorable. I mean, if you're a hospital CFO, you talked about this a little bit, but what do they do with that information? I mean, they get this unfavorable outlook revision, you mentioned kind of cutting expenses, things like that. I mean, are there decisions that they make based on that? Tell us a little more about how kind of that interaction happens.
Sure. So yeah, so our outlooks basically just indicate where we think that credit rating is headed over the next couple years. And it's a 1 in 3 chance that we think that rating could change downward if it's an unfavorable. So the hospitals themselves, there may be things out of their control, and they are, so they they're managing their business, and sometimes that affects the credit rating. And even pre-COVID, that might have affected the credit rating and the outlook. And we put a very detailed view of like what we expect. If these things happen, it's likely that the rating's going to go down, and these things will hold it stable. So it gives them a good guideline about what they need to, what would cause the pressure to change it. Now, whether hospitals will go and make adjustments, that's really kind of based on where they're at in their positioning, and they may be executing on a strategy, and they still need to implement Epic, and they're going to have to keep going and move through that, and that just might be a rating cut. So to them, it really is to look at it and say like, well, what can we do, what changes can we make? And they're probably doing that anyway because of the margin pressures they're feeling and the investments that they need to continue to make. And then it's really sometimes like the decision is made that the rating is a secondary thing, and they need to keep moving forward. But they will go and if they feel like they can adjust, they will try to adjust their revenues and expenses if that's the issue. But if it's a balance sheet issue, it may be something that might be a little bit harder to up to, especially given the markets and the way things are moving, to be able to adjust. So it really does depend on the credit and where they're at, and what's in there, what they can do, and what things are out of their control a little bit, and what their strategies are telling them to do.
So it's one factor, but not the only factor.
Yeah.
Great, thank you. Well, thank you for those presentations. So I will now turn it over to Mark Miller, who has some kind of wrap-up thoughts and reactions, and then we'll get into the Q&A. And keep those questions coming. They're fantastic. We're going to get to as many of them as possible.
Thank you for that, Sarah. So just a couple of things to get started. Given the depth of the economic downturn and the how critical the public health emergency is, I want to be very clear that I think it's absolutely important that the federal government intervenes to stimulate, to bail out, to support, families, businesses, and ultimately healthcare providers. But I also think for those of you who work with the Congress, it's also important to keep in mind that from a budget point of view, we didn't plan for this, and we've been carrying very deep debt for many years, and that debt now seems to be about the size of the economy, and an economy that's shrinking, meaning the ability to pay it off is somewhat compromised. And so I think, my starting point is we should be, judicious about how we think about the support that we provide to the healthcare sector, because all healthcare providers are not equal in their ability to kind of sustain and work through this crisis. And so, thinking about the $60 billion that hasn't been allocated, the potentially up to another $100 billion that could be allocated, the request to forgive the accelerated payments, I sort of think about support in two ways. One is, helping hospitals, for example, or in other providers, but probably fundamentally hospitals, with the unanticipated COVID expenses of, PPE, ventilators, the increased cost of, say, an inpatient admission related to that. And I think that's all legitimate. Should be some attempt at accounting, and then, helping the hospitals on that front. I think a lot more tricky, though, is lost revenue. And I think, if you're following the discussion carefully, on the one hand, you can hear some of the information that was presented here today, how difficult it is for the hospitals. But if you're following sort of the second quarter reports, and I don't mean just for, say, providers and hospital systems, you're seeing, very profit margins for drug companies, insurers, and then also some of the large hospital systems have been coming in with very profitable second quarters. High degree of cash flow. A real shock to me is some of these hospital systems have reported very deep reductions in their costs. And this is an industry that has generally argued that it has very high fixed costs, can only change cost over the long run, and yet seem to have responded pretty quickly. And so, and I want to be very clear, this is not all hospitals, this is some hospitals. And kind of related to what Karen was saying, is she was pointing out that some of the early allocations tended to go to the hospitals that had more revenue. And in part, that's because it went to hospitals that were able to charge in the commercial sector much higher prices. They often had strong market positions and were able to extract high payments. And so, one thing to think about in allocating is both the financial health of, say, the hospital, and also the market position of the hospital and its ability to extract high prices. And when you replace revenue, are you replacing revenue that's critical to keeping the hospital running, or are you replacing revenue that far is in excess of, say, their cost structure? So when we think about the principles around distribution, we tend to think of focusing on financially unstable providers. And I think we would look first at the all-payer margin as opposed to the operating margin, which is much high. It was about twice as high as the operating margin on average, and takes into account a broader set of revenues that the hospital has available. We would focus on hospitals that are serving Medicaid and a lot more uncompensated care, which tends to go hand in hand with a lower all-payer margin. And say hospitals that are critical to access, that if this hospital closes, then the ability for people, say in a rural area for a 50-mile radius, would be unable to get health care. And then by way, and I'm going to sort of start to close here, the other just couple of things I would say is that hospitals and other providers can in fact change. I mean, it's often an action forcing event. The question about telemedicine, I mean, there wasn't a lot of telemedicine. Then there was a lot. Hospitals have shown that they can contain their costs if they're put under pressure. And the other thing I would say is that we shouldn't be as an objective to trying to get back to normal. Normal was an extremely expensive healthcare system, for all of the actors in it, mediocre quality, it was complex, and there's clearly market failures like surprise billing and, say, the ability to extract really high prices in the commercial market. And that leads to my last thought, which is I don't think it's unreasonable that in targeting this help from the federal government, and even if it goes to well-to-do hospitals or to poor hospitals, it is not unreasonable to ask for things like refraining from surprise billing for, say, 2020 or 2021, or refraining from price increases that are faster than inflation for 2020 or 2021, because to the extent that we can control our healthcare costs, then families and businesses have a better shot at getting back on their feet and back to work. I'll stop there, Sarah.
Great, thanks, Mark, for those comments. So we have gotten a ton of questions from the audience, so we're going to dive right in. First, let's just get a little bit more of the landscape, and then we're going to talk about kind of who's been affected and how. And then we're going to get into some questions that we have received, a number of them around the $60 billion, the remaining $60 billion in provider relief that hasn't been allocated, and then there are a number of other questions that we'll get to. So first, let me just ask about a couple of specific types of providers that our listeners are interested in. One is rural hospitals, and maybe I'll ask Susie and Ken if you have sort of some initial thoughts on that. What have you seen as a differential impact, if any, around rural hospitals? We know that there have been challenges, and I'll add in all rural providers, really, as you have looked at your analysis. Susie, do you want to start us off?
Yeah, so I think, so the rural hospitals have been obviously under a lot of pressure for a number of years. So this is a little bit of a double whammy for them. To the extent that they have partnered with larger systems, I know in some cases we've seen that where they've partnered and tried to right size their facilities. They were maybe less impacted because they are now absorbed into a bigger system. But for sure, they were feeling, significant effects from the pandemic. And certainly a place where investment and how to care for those patients in the right way. I know there was a lot of telehealth and teletechnology going on that's been historic. So to that extent, that they are wired in, that's sort of helpful going into this. But certainly that's not the answer for all of the challenges that they have in front of them.
I would just note that obviously rural hospitals in America have been under tremendous pressure for the last 10 to 12 years, and it's not getting a lot better. We could do a whole separate symposium on that. I did have a CEO who has a large rural network tell me, however, that the emergency payments he got for being a rural organization were actually much larger than what he got from the CARES Act. So if that was true across the board, then the federal government recognized that that many rural hospitals could be significantly at risk of not being able to make payroll, actually running out of money. And they seem to have bent over backwards to make sure that didn't happen.
Great, thank you. We've also gotten a couple of questions around independent primary care practices or ambulatory providers, and I wonder if anyone on the panel can comment. Karen, maybe since you've been looking a lot at the data on sort of how this has been distributed, I mean, do we know how much of the relief has been distributed to, either independent practices or ambulatory care providers as compared to hospitals?
Yeah, that's a great question. I mean, to the extent that an independent provider or, an ASC or anyone else either was a Medicare provider or a Medicaid provider, they would be eligible for provider relief grants that amounted to 2% of their net patient revenue. So we do know that. It's hard to know, unfortunately, what share of the money that's been distributed went to those providers. In part, their HHS, I think, has actually been more transparent than they were required to be under law, and have released lists of how much money has gone to each provider. But, a lot of providers have gotten money, and at this point, there's about 300,000 providers listed, and their HHS doesn't go through and categorize them by type of provider. And obviously, at that point, it would be a tough slog for anyone to do that by hand. So we don't have a great sense of what share of the money has gone to those smaller providers.
Great. Thanks, Karen. And Billy, I wonder if you could comment too. And, there have been several sort of sources of funding, and I will sort of point out the Alliance did a briefing, a webinar on primary care specifically back in May, and of course there were a number of challenges, including challenges accessing the PPP loans. Billy, any sense on your end, or is this something Congress is looking at, or HHS, or how do we think about this issue? Billy, we're having a little trouble hearing you, so Billy, I think we're losing your audio, so while Billy calls back in, we'll hold that question, but I would refer those who are interested in primary care to check out the Alliance's May 20th webinar. And in addition, we also did hold a rural webinar kind of earlier on, so still something else that we can look at. Great, let's talk about the $60 billion, and I will also recognize that there is a giant tropical storm happening in the DC area, so hopefully we can all stay on the internet. There have been a lot of questions about the unspent $60 billion, and so let me first start with a specific one, and then maybe we can go more broadly. So one of our listeners asked about, in particular, the money to treat uninsured COVID-19 patients. So those unallocated funds to treat uninsured patients refers to one statement that an HHS official has made that said that they've only paid out $340 million so far for that purpose. It was much less than they anticipated. What is going on there? Are providers just not taking advantage of those funds? Is it slow to be allocated? Karen, do you have any insights for us on that, the funding specifically for the uninsured?
Yeah, I mean, I just checked today, and that figure is about right. It's about $350 million that's been paid out so far in claims. It's hard to know exactly what's going on. For some individual doctors, they may just not be aware of the program. Larger hospital systems, you would think, would be aware. One issue we've heard is that the patient had to be coded with COVID-19 as a primary diagnosis, and for some patients, by the time they get to the hospital, to the extent that they have other serious issues that may have been caused by COVID-19, those serious issues may be the primary diagnosis. So some of it may be some of the requirements around billing.
Thanks. So, well, and as we know from the earlier stages of the pandemic in particular, and maybe perhaps still continuing to this day, people haven't necessarily been routinely tested, or people early on with very severe symptoms couldn't necessarily get tested. So that may also have had something to do with it.
That's exactly right.
Yeah. Thank you. So let me just ask kind of another question along those lines. We talked, most of you really talked about kind of this issue of kind of speed versus accuracy in terms of actually allocating the funding, and so I wonder, initially if maybe if you were in the heads of officials at HHS, was it, a matter of let's try to get as much money out the door more quickly? I mean, is that why the funding went to Medicare providers initially? And going forward, if you kind of had a magic wand to wave and you could think about allocating and distributing those funds in a way that would, that you think would be more fair, how would you go about doing it? I mean, would you change the formula? Like, what would you be thinking about? Anyone want to start with that?
Well, Sarah, there was a couple things that I was trying to say there towards the end. I think we would look at, this is Mark, I'm sorry. We would look at the financial focusing on the hospital so far, since the talk has really had a lot of focus on that. Focusing on the financial status, and I threw out the all payer margin as one measure, but there are also other things, cash flow measures that have been spoken about and talked about in general and in this presentation. The proportion of your cases that are Medicaid and uncompensated care, and then how critical the provider is to access. And that one is a bit tricky in the sense that, if you had a rural hospital in which that hospital goes down, there's no access, that's pretty clear. If you're in an urban setting and there's 4 hospitals, you may begin to look at things like occupancy rates and that type of thing. But the focus would be on the financial status, and then serving or acting more as a safety net provider. I think you're right. There was a real attempt to just get things out the door, but also I think there was a real recognition pretty quickly that I think HHS was very surprised by how fast the money racked up in the accelerated payments in Medicare. And then I think some of the comments that Ken just made, and some of the stuff that was reflected in Karen's presentation, there definitely was much more of a turn to trying to target it after the first waves went out, and really we're kind of tracking to revenue as Karen's presentation showed.
Great, thanks.
This is Ken. You know, I think I would be the first one to criticize HHS. I just have to go on record for that. But I think they made the best decision they could under the circumstances. They used the metric that was easiest for them to figure out, which was everybody's Medicare payments. It was a number that they were able to get a hold of, I would guess, within minutes. Push a button, and there it was for every hospital in the United States. And so that was, you know, anything else was then going to get complicated, was going to cause delays. I think what they really, really didn't want to have happen was begin to have hospitals report that they were unable to make payroll and were laying off Americans in this situation, thereby making the economic situation even worse because the money had not gotten out in an effective, efficient, and quick manner. So under those circumstances, I think they did the best they could. But you know, you can certainly see that wasn't necessarily the fairest way of distributing the money, but it was the fastest way to distribute it.
Thanks. And we got a kind of a follow-up question from the audience. I mean, going forward, is there a straightforward formula that would, you know, kind of better target some of the funds to the providers in the greatest financial danger, who serve the lowest income or most vulnerable patients? How does Ken, you kind of alluded to the back end kind of data infrastructure. I mean, we know that like with Medicaid, it's, you know, if you've seen one Medicaid program, you've seen one Medicaid program. So, I mean, what's realistic going forward in terms of, looking at the data, looking at the numbers? Anyone want to take a stab at that?
Can you hear me?
Yeah.
Okay, this is Billy. Sorry, I was having difficulty earlier. I'm not sure what happened there. I'll take a stab at it. I mean, I guess kind of broadly speaking, one challenge we face, I think, is the sort of pre-existing financial vulnerability of hospitals aside, which I totally agree should be an important part, maybe not the exclusive, component of the formula, but a powerful one. But in terms of identifying hotspots, et cetera, the analysis is to some degree necessarily post hoc, and so there is this lag in delivering funds to the parts of the country that need them most, and that lag is fueled, unnecessarily due to the political dynamics afoot here, including the failure of some, not naming names, to perhaps take the pandemic as seriously as it should have been, as soon as it should have been. So now, hopefully, to some degree, we're on the same page in that regard. But you're still going to have the technical challenge of, I don't know if it is feasible. Perhaps some on the call do, to have kind of predictive modeling that would be reliable enough to base funding on it. But in a more perfect world, we would be looking at things like that, and obviously our government, would be have the capacity to be more nimble in delivering funds based on what that data would suggest.
Great. Mark, you mentioned kind of an all-payer standard as opposed to an operating margin standard. I wonder if you could just quickly kind of comment on, the kind of data that may or may not be accessible to follow up on what you suggest.
Yeah, and that's part of the reason that I suggested an all payer margin. So the difference between an operating margin and all payers is that the all payer encompasses all lines of revenue and other sources of income, as opposed to just, and I'm sure Ken knows the definitions better than me, and Susie as well, I'm sure, as opposed to the operation, meaning the delivery of services, the care that is organized around the patient. And so you can have other sources of revenue that would count into your margin. And the reason that I pointed to that is the operating margin in Ken's work was about 3%, I think, if I remember his presentation properly. The all payer margin has been running about 7, 6.5, between 6 and 7 for the last several years. And I think it kind of speaks a little bit more broadly to the broader financial health or lack of for a hospital. That data is available, and the other reason that I attached to it a bit is you can get it out of the cost report pretty directly, the Medicare cost reports, and so I feel like it's pretty accessible. The Medicaid and uninsured percentages, either as cases or the uncompensated care amounts, are also obtainable and could be used. And so, part of the metrics that I was and then I tried to say, the critical for access is a bit trickier, but at least some of those metrics are pretty available to CMS through either their cost reports, primarily through the cost reports, I think.
Great, thanks. Ken or Susie or anybody else, do you have any additional thoughts on that, on like the data that might be available?
This is Karen. I'd just add, there's been some talk on this call, and certainly in the press around the next aid package around the Medicare advanced payments, and either forgiving some of them or stretching out and creating a more favorable time period for hospitals to pay that back. And I just add, there's no equivalent federal advanced payments in Medicaid. Some states have provided some advanced payments to certain providers, but to the extent that people are looking at new ways of helping providers, thinking through which providers maybe have gotten less help so far and may still need more assistance, may make sense.
Thanks, Karen. And we talked a little bit about Medicaid, and you had raised some of the challenges around state budgets, and Susie as well. While that's not a specific form of aid per se, it's a payment structure for a coverage program, Medicaid. I just wonder if if you or other panelists could sort of talk about more specifically how are you thinking about Medicaid as a source of provider stability going forward?
Sorry, was that to somebody specific?
Yeah,
Is that to me?
If you wanted to start, or
Karen,
Susie,
sorry.
if you wanted to.
I was going to jump in, but go ahead, Karen.
No, Susie, why don't you go ahead and then I can fill in.
Yeah, so the Medicaid, I mean, it's a really interesting, it's an interesting one. Obviously, it varies, 50 different ways, and what different levels of support are out there. I mean, we have a lot of providers that, on top of Medicaid, get provider fee program or get provider fee funds and other supplemental funds from states. So we do look at that holistically. But in certain states, and certain credits, I think someone mentioned earlier, like it is going to be very credit specific. I mean, Medicaid, we are concerned because of some of the challenge. It's the biggest part of some of the state budgets. And those cuts, as they come through, or if they come through, that would be especially for those safety net and some of the hospitals that have more Medicaid exposure, that would be a challenge. And so it is something we're watching, but we also look at it with those provider fees, and it gets a little complicated there, but those seem to be like holding up right now. And it really would depend on sort of what your exposure is to the Medicaid. So if you only got 3 or 4% or 5%, 7%, you can probably adjust. Obviously, if you're a children's hospital, it makes it a little bit harder. Those are exposed to Medicaid quite a bit. So, it's not the best funding source for hospitals, but with the FMAP, it's helped, and obviously with some of these additional supplemental funds, it's held up. But it's a definite area of concern for our hospitals.
Yeah, and
Thanks.
for some of the for some of the smaller providers providing like behavioral health and other services, often Medicaid is really their only source of revenue, and when states don't have a lot of options, when the economy is weak, and may cut revenue, at the very time when they might be seeing higher cost. So I think a lot of those smaller providers are quite vulnerable right now.
Thanks. And we did have a follow-up question on Medicaid from the audience around the deadline for the Medicaid portion of the Provider Relief Fund, and asking why that deadline has been delayed multiple times, and this person kind of reflects some uncertainty about what the barrier may be. Do you have any thoughts on that, Karen?
I haven't spoken with providers directly, but, unlike with Medicare, whereas Ken said they had some of the data, the providers had provided data and cost reports before. On Medicaid providers, this is new data they're pulling together and providing to CMS for the first time. A lot of these are smaller providers. The FAQs and some of the technical instructions providers are getting are continually changing. So I think it's led to a lot of confusion that maybe have caused some of these delays.
Great, thanks. All right, so for the next kind of 15 minutes or so, I'd like to turn to kind of some of the more forward-thinking implications. And let's just start with health equity. I mean, there's been a tremendous conversation around racial inequities in health in general in this country, as well as we know that COVID-19 has been more prevalent and more deadly among people of color. What do we know? What data do we have around, whether federal relief is reaching providers who are caring for populations who are disproportionately impacted by the pandemic? And is there a way for policymakers to think about advancing health equity in future COVID relief bills or actions? Karen, since you did some of the analysis around safety net and kind of the allocation there. I mean, does any of the data kind of help point to that question?
Sure. I think when we did our paper, the additional about $13 billion for safety net hospitals hadn't been announced or distributed yet, and I think for hospitals that has at least helped directionally, but we haven't seen any equivalent money for non-hospital providers, so things like community health centers and also other local clinics that may see more uninsured patients, more patients on Medicaid, maybe don't command as high rates from private insurance, and they similarly were disadvantaged by the formula of basing grants on 2% of patient revenue. And I think, at the same time, there may still be, some rural hospitals, some public hospitals, and others that were, even though they got extra assistance, they may be in a particularly vulnerable state right now. And, at the same time, we see other providers, again, reporting, positive earnings. So I think it's definitely something to keep in mind as we go forward.
Thanks. Billy, do you have any thoughts from the policy perspective there?
Sure. Yeah, I was just wanted to note that the Congressional Black Caucus had a package of proposals in May, some of which were included in the CARES Act to try to specifically address racial inequity and protect minority communities in the COVID pandemic. And just for, I mean, for one thing, they strongly advocated for and attained the requirement that the CDC track racial demographic data in their tracking of the COVID pandemic spread and testing rates and so forth. There was also about $500 million specifically targeted to historically Black colleges and universities to help them, obviously continue their mission and operations during the pandemic. So there have been some efforts, directly to try to address racial inequity. I mean, the only thing else that I could say is that well, I don't know which is more difficult. I take that back, but it's hard to resolve racial inequity, and the implications of our policies kind of on the fly like this. I personally hope what we're learning is that you really have to take a step back in a broad view and address the systemic racial inequity and racism that we have in our healthcare system, so that we don't see racial inequities when the next pandemic and other crises hit.
And if I could just add one thing, I don't know as much on the policy side, but I know from our healthcare providers, they're doing a lot of it. They've historically, especially the big systems, have started to do a lot more work around some of these areas and the social determinants of health and trying to improve the equity of care. And to the extent that there's more operating challenges, because that's not always funded. I mean, they've tried to invest in that, but that becomes an area that becomes a pressure point going forward if these systems are more depressed from a margin standpoint and can't do it.
Mm-hmm.
This is
Susie,
Ken.
This is Ken.
Yeah. This is Ken. I'd just like to comment. This isn't a problem that can be addressed now, and it can't, and it isn't, and going to be addressed by the money that's available now. This is a problem that's been in the making for 60, 70, 100 years, and has to do with the way the care is provided in communities of color, the lack of access, the lack of convenience, and the lack of primary physician care, and the ability to quickly identify developing problems like diabetes and obesity and others, and then find a community appropriate way of dealing with those issues. And we've all worked to create this problem over a very, very long period of time, and it's going to take quite a while to fix it. And it's going to take a completely different attitude on the part of our healthcare system and on the part of our state and federal governments to figure out how to change this, so that the next time one of these pandemics comes by, it's an equal opportunity problem and not a problem that is burdened to communities of color disproportionately.
Thanks, Ken, and thanks everyone for those insights. So let's talk a little bit about payment reform, and I wonder if anyone, we've had a few questions about this, so I'll try to kind of synthesize them. First of all, I might ask Susie from your perspective to start with this, but obviously would love for others to jump in. Have you noticed risk-bearing health systems or systems that are moving more towards value-based care demonstrating better operating performance, or how are they doing in this pandemic compared to the more fee-for-service heavy folks?
So it gets a little tricky here, but I will say on the hospital side, those that had obviously the integrated providers that had the insurance and had that capitated revenue coming in have fared better, just having that hedge, that natural hedge. So I think and in terms of if you had capitated revenues as a system, certainly that helped to outside of the insurance, helped to maintain revenues at a time when everything was, going south from the fee-for-service side. So definitely have seen that. So to the extent that, when there is a moment to kind of catch your breath, it does feel like this could be, could be the impetus to kind of keep pushing that kind of reimbursement or that payment change forward. So that's definitely something that we have seen. The value-based portion, in some markets, it feels like it has paused a little bit in certain places just because the attention can't be there given the current sort of crisis. So we'll see where that lays out. But I think, places look to Maryland and places like that where they've got a little bit more control on the payments schedule, that has helped too. So I do think that this kind of like with that sharp drop that happened in March and April, that this does sort of open different eyes to sort of advantages and different payment methodologies. So hopefully that'll, continue to push that forward.
And if I could just add a couple things there. There had been work at MedPAC on re-examining the thought would also apply to the commercial sector and could apply to Medicaid as well, but of trying to move primary care to much less of a service by service reimbursement and have something more of a per patient blocked type of payment. And a point I tried to make earlier is there is this notion of like, well, let's just, put money into the system, kind of get back to where we were. And I really would, counsel against that. You have a lot of churn, you have a lot of change. You could be also taking up policies that have been out there as part of the Congress and beginning to, or continuing to, as I think Susie was saying, is to push forward with some of the changes, and that might put primary care both on a more stable, might be a more rational way to pay in general and a more stable basis for a future, crisis like this. A couple of other things that I just sort of held back and let other people respond on. Also, I think some of the targeting, if it goes to safety net providers, it won't change the problem that you raised about racial inequities, but also it won't, it might not, it won't solve it, but it could help. It could at least not make it worse. And also on the same track, we're thinking about here about how to care for like complex care populations, like the dually eligible population in both Medicare and Medicaid, who really did get hit fairly hard by the epidemic from a nursing home perspective and being overrepresented, minorities being overrepresented. And there's some issues there with consolidation of care and coordination of care between Medicare and Medicaid and responsibility for providers that might have some, again, this is looking over the horizon as opposed to the immediate crisis, that could have something that could help in the future to try and correct some of the inequities. I'll stop there, Sarah.
Thank you. So kind of speaking of looking at the horizon, and we have just a little over 5 minutes left. So I think, this might be kind of one of my final questions. So I would ask each of you, what do you foresee, that this crisis portending for provider markets going forward? Will it accelerate the push more to value? What do you think is actually going to happen as a result once we kind of get through the immediate fog of war, if you will? And maybe why don't we just start in kind of reverse speaking order? So Mark, can I ask you to start off with that? What do you think is going to happen over the next few years to provider markets as a result?
Well, I'll tell you one thing I was afraid of happening, particularly when the first kind of waves of, and I want to go fast because we only have a few minutes. when the first waves of help started to roll out and where it was going, I have a real concern, and you know this, we've had many conversations about it, that we not be accelerating consolidated markets. There's a tremendous amount of consolidation in the hospital market, both horizontally and vertically, and then increasing consolidation in the physician market. And so the thing I would say is, I'm concerned that that's happening. And then when the help started to go out in its initial directions, I was afraid we were contributing and pushing that even further down the road. And I don't want to take a bunch of time, so I'll stop here.
Great. Thanks. Ken, what do you think is going to happen? The crystal ball. Oh, I'm sorry. Susie was, I'm not doing a good job. Susie, you are up.
Sure. I think, so I think with all of this, obviously there's gonna be a lot of, I think it'll be just still that push on, the overall costs in the system and trying to lower that, and of course, continue with quality and all of that. But I think the costs are going to be a big component, as we've seen, just from a reimbursement standpoint. I mean, more and more Medicare, more Medicaid. So there's going to be a very sort of concerted, continued focus on costs, using technology and data to try to lower that cost, is where I think a lot of the focus is going to be over the next couple of years. And I hope that, from what we've seen, that the reimbursement and the payment methods, that we do see the importance of public healthcare institutions and better payment models, and that we can work to insure more people, and so we're not in that situation where there's a lot of uninsured and underinsured. But those are the things that I hope for. But I think there's going to be a lot of focus on hospitals from costs and technology to improve that.
Thanks, Susie. Okay, now Ken, you get to go.
Thank you. Hold on a second. Thanks very much. So I think I would quote Jim Collins here at this point, and Jim says, in extreme crises like these, the separation between organizations tends to be permanent, and those organizations that start out weaker tend to fall further behind. And I wouldn't be surprised at all if that happens. And much to Mark's despair, that will lead to further consolidation in the provider market.
Thanks, Ken. Well, so next we will go to Karen.
Thanks, and I'll just echo what Ken and Mark said around consolidation. I think there is a real danger that this could lead to more consolidation, which, if we're not careful, will lead to higher prices. KFF put out a paper today on the impact of consolidation that reviews past research that shows this. And of course, those higher prices would lead to higher premiums for people with private coverage.
Thanks, Karen. All right, and so Billy, you get the last word. What trends do you foresee?
Sure. Well, I think that the genie is out of the bottle a bit with telehealth, as with other aspects of society. We don't quite know where we'll recenter after COVID passes. Will people elect to get their services remotely more often? Just like are they going to go back to movie theaters in the same rate they used to before? We don't know that, but I think that there will be some of those relaxing of the prior restrictions on telehealth will be maintained. I just quickly, in 30 seconds, I'd also add that I think there's a question about not just the kind of financial health of hospitals going forward, but public and political perception of the financial health of hospitals going forward. What impact will that have on questions about surprise billing? In Colorado, we had an effort around a public option that pulled back in part because of sensitivity around hospital finances in the COVID pandemic. So once the dust settles, it'll be interesting to see if their leverage has increased or decreased due to what we've been through with this.
Thank you. And, anytime we sort of say future pandemics, I always get a little short of breath because I know we've barely gotten through this one. But of course, we will also need to be prepared for future disasters as well, unfortunately. So with that kind of Debbie Downer comment, I do want to thank all of you for what's been a really insightful and thorough discussion. We thank our audience for sticking with us and for all of the great questions, and encourage you to reach out to us if you have any additional issues or topics that you want to see covered. Thank you so much. So moving forward, you're going to get to see a recording of today's webinar or hear a recording on our website soon at allhealthpolicy.org. And for more pandemic news, please join us tomorrow from noon to 1 o'clock Eastern Time. The Alliance will be holding a webinar on the immediate and lasting impacts of COVID-19 on children. So we hope to see you there. And finally, please take time to complete the brief evaluation survey that you'll get immediately after the broadcast ends, as well as by email. So Billy, Karen, Ken, Susie, and Mark, thank you so much for joining us this evening. And we look forward to staying in touch with you all. All right, this concludes the webinar. Thanks, everybody.
Take care.